Lisa Apfel, neurosurgery. My specialty is mostly pediatric, but I do a little bit of everything. Trauma, a lot of trauma. Um, any questions during the presentation, just feel free to just speak up and ask. If you do it via the computer, I'm not very computer savvy, so just go ahead and interrupt and speak up and ask, as we're going. And I just was going to do basically a clinical overview of hydrocephalus. And I was not really going to go into the nitty gritty of the science and the theory today, but rather just really focus more on the clinical, which I thought would be good for this type of talk. Just types of patients, if you see, what do you think? How do you approach them? So to start with, going to just briefly review what is hydrocephalus, types of hydrocephalus, because there's a lot of different types, and then basically how we work up a patient, and then some of the treatment options. And there are volumes written on each one of these topics, so I'm really going to kind of do an overview of things that we commonly see and things we commonly need to think of. Okay, so basically, what is it? In general, the first thing we think of with hydrocephalus is an excess of cerebral spinal fluid, which usually is from inadequate absorption, but it can be from a blockage of flow, which could be from a narrowing, it could be from scarring, infection, tumor, which then causes spinal fluid to build up in the ventricles, and then because of that, then we're not getting adequate absorption, but yet we have the ability to absorb if we didn't have a blockage. And that's important because then that may change what we do treatment-wise if we need treatment. Okay, so generally we look at types. We look at patterns. So is it communicating where all of the ventricles are enlarged, or non-communicating or obstructive where some are maybe normal and others are enlarged. And the most common form of that would be something either in the posterior fossa obstructing or aqueductal stenosis. In pediatrics, those are the two most common things we see. Then the other thing we consider is, do we have high pressure, low pressure, or normal pressure? So we'll throw out NPH today for the talk just because that's usually older adults, and that's normal pressure is hydrocephalus we generally do not see in kids. Usually we have high pressure hydrocephalus where it's just a buildup, improper absorption, and we often need to do a procedure, either a shunt or I'll talk about another procedure later as well. Like very rarely, occasionally we see low pressure hydrocephalus that needs treatment. And we see it probably a few times a year, occasionally in kids, but it's really, really uncommon. So I'm really going to focus more on the high pressure because that's really what you're going to see. So there's other types of hydrocephalus we need to be aware of when we're looking at pictures. And when we get a call that says, hey, somebody has, these enlarged vents, it's not always something that needs treatment. So for example, if somebody has a stroke, they may have ex vacuo hydrocephalus, where it's really normal pressure. It's just spinal fluid taking the place of brain tissue, and that can happen, for example, after an in utero stroke. There's also compensated hydrocephalus, and that can happen in many different scenarios. It can be after trauma or just found incidentally. It can be after those things, or sometimes it can be triggered by certain things where somebody has compensated hydrocephalus, but then trauma may lead them to no longer absorb fluid. So basically, what the theory behind that we think is that there's a stage where there's insufficient absorption, the ventricles enlarge, and then the patient is then able to absorb what they're making, but the ventricles stay somewhat enlarged, but yet the pressure then normalizes. And some of those patients will then never need treatment, or some of them will, after, for example, a minor trauma, lose the ability to absorb and then need treatment. And if they do not have high pressure, generally they're asymptomatic, and generally we do not see what we call transependymal flow, where the spinal fluid is pushing out because of high pressure, pushing through the ependymal lining of the ventricle into the brain tissue. And you can see it on CT, but it's best seen on an MRI. So if we have a patient with hydrocephalus, how do we work the butt? Basically, are they symptomatic? Nausea, vomiting, visual difficulty, ocular movement issues, for example, up gaze palsy. They could have seizures, listlessness, drowsiness, coma. Now, any of these symptoms, findings can be for a million other reasons. They're just common things with hydrocephalus. So we also want to consider if we're seeing a patient with hydrocephalus, is this new? Is it, do they already have a diagnosis? And is it communicating, non-communicating? Do we think it's high or low pressure? And is there an obvious cause, like a narrowing or a mass? Okay, so let me see if I can move this out of the way so you can see the picture. Okay. This is a great example. This is an infant with enlarged lateral ventricles. And so frontal horn, this is temporal. This is the third ventricle, which is really round and it should be more straight. It actually have a little bit of a waist to it. And this is just very round. The fourth ventricle is also enlarged. And this dark space here, this is some transependymal flow. And we can also see some suture splitting here. So this is communicating hydrocephalus with transependymal flow, likely high pressure. Here's an example of aqueductal right here. You can see the aqueduct is narrowed and the fourth ventricle is small. There's a large subarachnoid space here, but that's irrelevant. The fourth ventricle is small. The corpus callosum here is rounded and bowed, pushed way up with large lateral ventricle and a large third. And so this is aqueductal stenosis. I can't tell you what the pressure is in this patient. And it could be chronic bowing and compensated versus it could be high pressure. I'm not sure, just based on that one image. We would need a flare to tell more than that. Here's a great example of a posterior fossa tumor. So an obstructive lesion, the fourth ventricle, it's in the fourth ventricle, and this is part of the fourth ventricle. And the third ventricle and lateral ventricles are larger than normal. Okay, so another thing to consider is in the history is that there was a recent trauma, recent infection, hemorrhage, a recent surgery, because we can have acquired hydrocephalus. And a lot of the times that needs treatment, a lot of times it doesn't. So, for example, here is an infant that has strep meningitis shortly after birth. And all of these pictures I'm going to show you here are the same infant. And we see ventriculitis, so this is a contrast eye. We see lining, the contrast enhancement lining the ventricles and the subarachnoid space all the way around the brainstem. And this unfortunate child went on to develop multiple cystic lesions all over the brain. And so here's the lateral ventricles blown up. These are all cystic lesions. There were multiple procedures done on this child. And many catheters, his brain, everything really calmed down and his brain formed beautifully. And he's actually doing fairly well. Okay, so another population to consider is premature infants. So they have a propensity to have intraventricular hemorrhage. And just to review real quickly, grades of IVH are 1, 2, 3, 4. So 1 would be hemorrhage in the lining of the ependema, germinal matrix hemorrhage. Grade 2 would be intraventricular hemorrhage, but no ventricular enlargement. Grade 3 would be intraventricular hemorrhage with progressive ventricular enlargement developing hydrocephalus. A lot of those kids will go on to need treatment, but not all. Some of them will compensate and start absorbing. Some may need ventricular taps, and some don't. Grade 4 is actually a little bit of a misnomer because it's not intraventricular. It's actually hemorrhage that goes into the brain parenchyma, and it does not necessarily increase risk of needing a shunt. Okay, so here's a sound. We see fullness of the lateral ventricles. We see some hemorrhage here. We see fullness of the temporal horns. These should be either slits, non-existent or barely existent. So this is all indicating lack of absorption, and it's not an ex vacuo picture. There's a lot of fullness, rounding, And we look at something called the Evans ratio. So where these dots are is not exactly right. It should be the largest, the numerator is the largest by ventricular distance from here to here. The denominator is the largest by parietal. So you take the same line, parietal distance. So this width should be about 30% total by parietal. In this case, this is probably just over 50%, so more than normal. Here's another case of an IVH baby with, this one also had some hemorrhage into the parenchyma grade 4. And then when the hemorrhage started to resolve, we shunted. And I'll show you a picture of this one later, what it looks like now. It's amazing. So this side is larger because of loss of tissue. And okay, so going back a couple steps. So we have an IVH baby. What do? We follow anterior fontanelle. We look for fullness and firmness, A's and B's, bradycardia. How much are they tolerating their feed? Because there's a very strong brain, gut, neuro, GI axis relationship there. So we look for, on exam, splitting of the sutures, especially the sagittal suture. I look for the closest point of the parietal bones. So I have something that I can reproduce on exam. So it's not anywhere in the suture, it's where they come together the closest. Same picture again, just to show you the Evans ratio, hemorrhages here. Okay, so now let's go to just a patient in the ER. You're getting called on somebody with hydrocephalus. Here's their picture. They have somewhat irregular enlarged ventricles. So do they have a known shunt? In this case, there is a catheter there. Presumably it's a shunt. It's not always. And then what type of shunt? And then what's their baseline? We have to think about all the clinical things. So just because they're a little bit enlarged, they could have high pressure. It might be low pressure. We want to compare to a previous MRI or CT when the patient was doing well. Here's another patient, small ventricles, but that doesn't necessarily mean that the pressure is low. You could have lack of compliance with the ventricles and increase in pressure with the ventricles getting large. It's rare, but we do see it. Okay. Not all catheters are shunts. So in this example, this is an Ommaya reservoir. And I'll go back in a second and show you the difference, but this is a rather large tapping chamber for chemotherapy in this patient with lymphoma. I'm going to go back here to this. Look at this tiny little reservoir. That's the tapping chamber in the shunt. That's attached to the valve and the Ommaya. It's quite a bit bigger. They're about, I think the smallest one is over 10 millimeters, and the bigger one is about 20-ish. Okay, so in the workup, I talked a little bit about the imaging. We want to compare to a time when we look at the overall size and compare to a time when the patient was doing well. If there's drastic enlargement, common things are common, it's probably shunt failure. Keep in mind that that's not always the case. The ventricles might be the same and they could possibly still be in failure. If the vents are significantly smaller, then it's not the shunt. Okay, so shunt X-rays. There's a couple things to point out when we look at X-rays. So we can look at the type of valve, and we can look for discontinuity. So here's a fracture of the catheter. It usually happens when, with growth, scar tissue attaches to the catheter, and then with growth, it snaps. There's usually a scar tissue tract that fluid can go through, but with time that can block off. Here's another example of a catheter fracture. Here's the end of it. And then we have the two ends down here just free floating. This is a peritoneal shunt. So it's in the sterile space outside of the bowels. And that's the standard for shunt. It's the best place for fluid absorption in most patients. Okay, here's just an example of standard shunt series looking at the catheter. So here in the peritoneal space. And it really doesn't matter where the catheter is here, as long as it's not tightly coiled and we're worried it's in the preperitoneal space. If that's the case, well, there's a couple of reasons for getting another x-ray. If we can't tell, if we're just not sure where it is or we can't see it well, we get a different view, oblique or lateral. Or if we see it coiled, we can get a lateral to see what's the depth of the catheter, to see if it's in the preperitoneal space. And for example, this skull x-ray, we don't visualize the catheter very well. Here it is in the head. It's the reservoir is right there, and we kind of lose it. So in this patient, I would recommend a lateral x-ray so we can see it better. We can do an ultrasound of the abdomen to look for pseudocyst. And now the cysts can be infected, but not always. Sometimes they're very easily dealt with. We can get laparoscopic procedure done by general surgery to drain and culture the fluid, and then we reposition the distal ends of the catheter outside of the cyst. And a lot of times that's all the patient needs. Okay, so now as far as the workup, shunt tap. So if we want to determine the pressure, the proximal patency of the catheter, or check cultures, we can tap. So for example, if a patient is symptomatic and they had surgery 4 to 6 weeks ago, let's say, and they've got fevers and there's no other cause of a fever, that's a perfect example of a patient I would want to tap to check pressure and definitely to get a culture. If we're more than 6 months out from a shunt surgery, then the chance of it being infected is awfully low. Okay, so we can talk a little bit about why shunts get blocked. Usually it's just our own body's tissue blocking it. Best example is choroid plexus growing into the tip of the catheter. We can have our own protein just blocking it, and it's usually at the distal or proximal tip, most commonly proximal. Pseudocysts can build up and have enough pressure that it's actually blocking the flow, the outflow of fluid, even though the catheter is patent. And then with fractured shunts, the scar tissue can actually block as well. Now we'll move on to treatment. And so if we're going to place a shunt or revise a shunt, the go-to standard is peritoneal. And I showed you some pictures of that already. Another option, let's say there's a hostile abdomen for various reasons, we can do a pleural shunt. We can do a ventricular atrial shunt. So here is a ventricular atrial shunt. It just goes into the facial vein and internal jugular vein, goes into the atrium. And if we had a pleural shunt, it would come down the side here and usually under the 5th rib and then go into the pleural space. Things to be concerned about with placement of any given shunt is what are the structures you're operating nearby, and post-operatively things we watch for will be dictated by that. So for example, ventricular pleural with the tunneler goes down the side of the neck, over the clavicle, over the chest wall, and apex of the lung, chest wall, and then into the peritoneal space. So we can have vascular injury or neural injury in the neck. We can have pneumothorax, and we can have bowel perforation. For a pleural shunt, we are going into the pleural space, so we know there's going to be a little bit of air there, but so we have to just check an X-ray post-op and make sure there's not a big pneumothorax. And atrial shunts, we can actually give a patient congestive heart failure if they can't handle the fluid. So not all patients are going to be ideal for some of these procedures. So post-operative, we monitor for seizures, intracranial hemorrhage, and ileus, pneumothorax, bowel perforation. Usually monitor overnight. If they're asymptomatic, they can go home the next day. So now, let's say we have a patient that has an obstructive pattern, for example, aqueductal stenosis, and they're symptomatic, and we want to treat them. So then we can consider this procedure endoscopic third ventriculostomy. We put a neuro endoscope in the head, and we make a hole in the bottom of the third ventricle, so the spinal fluid can go through and be communicating with the subarachnoid space. And if the patient has the ability to absorb, which you don't know unless you do the procedure, then if they have the ability to absorb, that's all they may need. It works in some communicating patients, but it's not as effective, and it works best in patients greater than 2 years old. with no history of any kind of CSF infection. And in infants, it often works better when you combine it with a coagulation of the choroid plexus, which makes the spinal fluid. Any questions? I will keep going. So here's a patient that I showed before, infant IVH'er, grade 3 and grade 4, lots of tissue up here, and that's why this side then expanded into that. And now this is a year later, and there's beautiful brain growth. And you can see that this side here is a lot fuller than this side, but there's still a significant improvement. All right, I will wrap up. And any questions?